Welcome to Accelerate. Today we're here with Naomi, and she's helping build Cascaid Health, a proactive health platform that's applying elite sport methodology to consumer health and longevity. Naomi's leading on ontology, data standards, assessment design, and practitioner education. Welcome to Accelerate, Naomi.
Thanks, Nicola. Good to be here.
You built systems at the FA, you've turned research into coach-ready workflows. Now you're doing something similar with Cascaid, and this is more at a consumer health level. What translates directly for you, and what have you had to completely rethink when you're looking at consumer health compared to elite level sport?
Yeah, so I think in terms of translating, the physiology translates. So that's really key. It's kind of universal throughout, but the operating environment is different compared to elite sport compared to that consumer health environment, particularly at Cascade. So both of those are goal first designs. So we don't start with like diagnostics, for example, in the health space or sensors in the elite space. We start with a goal. So in the elite world, that was a performance problem. And so before we would do any type of intervention, there needed to be a reason for that intervention. And the performance problem would be a problem that was designed, identified, collaborated by either a group of coaches, the performance coaches, both the technical coaches, and even kind of performance and medical staff, depending on the performance problem. And so it was derived by the people that you're trying to serve while solving that problem. And that's what's really key. And it's the same in consumer health. In terms of what we're doing at Cascade, it's a goal first design. And so our health seekers coming in, they have a goal. We need to pull out what that goal is, but at the end of the day, they author their own goal. And we don't start with just running diagnostics and seeing what's wrong in some cases. And it's the same in elite sport, because you're not just going to put players through tests for the sake of tests to gather data, for the sake of gathering data. There has to be a reason for that. And so the central piece there is the performance problem. Everything starts from that, and that applies in consumer health as well.
Yeah.
And then secondly, I would say that decision rules are kind of more important than just dashboards. And so we kind of have a tendency to, like I said there, collect lots of data and produce lots of brilliant looking dashboards. And we did this in elite sport as well. But it doesn't matter how many dashboards you have and how great they look. If there's no actual decision rules around that data, what do you do if this is trending this way or this is trending that way? If there's no answer to that, then we're stuck and we don't get anywhere. And it's the same in consumer health. And so we don't just want to report something. We actually need to have some rules about if, then, and where we're going from that point. So that's the second point that translates directly, I think. And then thirdly, I'd probably say baselines and trends. And so we don't just look at single numbers, single values on their own, like one single metric, for example. And that was the case in elite sport. We're not just looking at distance covered on a pitch as one single metric. And if one player's covered more distance than another player, it means that player must be better than the other player. That's wildly out of context, and I think most people would understand that. And it's the same in consumer health. Like we wouldn't want to just look at one value, one number, one blood work metric and have that tell the whole story. It doesn't. We need to have the context that backs that up, but also have the trends over time. So just looking at a single number at one time point doesn't give us enough context to make a strong decision on an intervention. It's the same in elite sport. We'll be looking at baselines and trends over time to see whether there is any meaningful change based off of any interventions that we have prescribed, for example. So I think those are the three things that translate directly from elite to consumer environments. And for the second part of the question, which I think was what I've had to rethink. It's It's probably a little bit of experience, actually, like coming into working in those elite environments previously. Actually, through that process is learning buy-in and trust. And buy-in is the biggest barrier to success in terms of that outcome goal. And too much information like blocks the adoption of any type of intervention that you want to try and implement. And so that's something that in an elite environment, it's, I suppose the structures are in place to design faster feedback quicker. In a consumer health environment, that's the difficulty, is how do you design fast feedback? Because it's almost the same principle in terms of buy-in and trust, but there's almost an extra step because you're not seeing these people every single day like you would in an elite environment with the players. You're building rapport with them and the coaches. I've had to rethink how we design that fast feedback, how we deliver that feedback, and how we set expectations at the start. And so, the difference between being in that full-on environment where you're in person and you have that kind of trust that's built up kind of in a short space of time, to a consumer health environment where you may not see the health seeker like on a weekly basis or even on a monthly basis. It may not be that many times a year, but you're still having those touch points with them, and that might be remotely as well. So actually, I've had to rethink, like, how do I build that buy-in and trust with our consumer health seekers and also colleagues as well, right? In this environment, we're not all in the same place at the same time. Everyone is an expert in what they do, but we're trying to almost meld that together, and it's an extra step, I think, in consumer health compared to an elite sport.
Yeah.
And then I think another point I'd say is the time cost as well. Like, that's really important in both environments. In the elite environments, in kind of when I worked at the FA, I kind of designed some dashboards and things to try and reduce, I guess, practitioner burden via like automation of those dashboards. The consumer equivalent is, instead of just chucking dashboards at health seekers, is probably the same principle in terms of reducing the friction and making that next step really obvious to the consumer. So there's less of a kind of cognitive load. They have to actually make that decision. It's, can we make this next step as easy as possible and really obvious, like which route they could take. So yeah, I think those are key. I think maybe the final point is turnover and changing context. In an elite environment, there's always staff turnover. It's kind of a symptom of being in such a high pressure environment. It's always going to be there, and so you have to deal with staff turnover, shifting philosophies. If a new coach comes in, that might change what they want to see. And if you're doing a research project, for example, that was based on a performance problem from a previous head coach, and they come in and have a different philosophy, then you need to figure out how to adapt your existing project to meet what they would then kind of design as their performance problem. In consumer health, I'd say like the parallel is almost changing routines for health seekers. Like they might change their routine through unforeseen circumstances, stress, could be their life stage, for example. And so systems have to adapt in a slightly different way to what they would in an elite environment, because there is staff turnover, but almost the context of the players and on the whole, their routines would stay pretty similar. In the consumer health environment, you've got no control over that. And I suppose that's the key. It's the lack of control that you have in that environment compared to an elite environment. And so same engine, different constraints in the two environments is probably the key to summarize that.
Yeah, I think there's so much that you kind of mentioned there that there's a couple of things I want to kind of pick up. you you mentioned like consumer health, but the reality is like consumer health is kind of people getting their head around that aspect is relatively new. I would say probably, and as there is a geographical kind of context element to this. In the UK, we healthcare systems have generally been reactive, and therefore a lot of what we're talking about just doesn't happen, even without the kind of transfer of money. It's a very, I would say, transactional system. So a problem happens, what do we do to solve it? But how that you're talking about kind of the systems that you put in place and how we look at things over a longer period of time and reduce that kind of friction, I would not say they are traditional design thinking or systems thinking kind of way of viewing healthcare. So while we've obviously kind of referenced the difference between elite sport and consumer health, I actually think what you're building at Cascaid, it's becoming more like this is what people want, but it's still quite novel. So that ability to kind of apply your knowledge from elite sport to a company, Cascaid, who happens to be sitting in consumer healthcare, as I say, is a real kind of behaviour shift. And I do think it's being driven by kind of multiple factors. It's being driven by people actually wanting it, consumers of their health wanting it, but it's also it is related to the fact that we do have the ability to have data on people now, and that didn't happen because it's rather than the healthcare system saying have this wearable, it's the consumers already saying I have this wearable, and therefore who's going to look at my data. And I think that's that really key aspect, isn't it? It's like what you're talking about there from a goal-based system. People have the data, they kind of know what they want, but you're able to create the framework or the architecture around their decisions to help them achieve their goals that they want to do. And I think before I hadn't really thought of it in that goal-based setting or that goal-based, but that is what people want in performance and in sport. And that thinking of flipping it to health takes a much more proactive, longer term view. So you come away from that transactional aspect and you start to create relationships with these users and these seekers of good healthcare. When you look at your work, you've looked to kind of integrate diagnostics with wearables, with lifestyle data, clinical inputs. How do you go about kind of building a knowledge system that makes sense of these signals that traditionally weren't designed to talk to each other? They've been quite silo, and yet you're being able to kind of create this system based on the goal that someone wants to achieve.
Yeah, and I think I agree with all of that. It's so important now because people have more access to data than they ever did as well, right? Like you've got access to the data on your watch. Like it's so accessible, and the different wearables that you have, they will produce different numbers and values, and it's great that people have access to that, but I also think there's a little danger in being over reliant on what your wearable is saying, and then you're constantly looking at it all the time. So for us, we're kind of taking all of that information, we're trying to integrate those diagnostics, that the wearables, the lifestyle data, the goals of the health seeker, and build a knowledge system that actually supports that and helps make decisions. And so for me, I could probably summarize that into maybe 4 kind of key points. Firstly, when we're building this knowledge system, which is probably one of my main roles at Cascaid, is building that, is firstly there's like a kind of triage filter, let's say, when we go into this. And the first thing is trust. Is the signal valid enough to act on? And that's really important because we're getting so many metrics, so many data points now. We need to be able to wade through that and actually understand, well, which ones can we actually use and infer and understand, like if they're valid or if they're not. And I think when we ask, can we can we trust this signal? We look at validation in layers, and that's how we've built this into our ontology, or our knowledge base. And first, is the sensor itself verified? So where the data comes from. Second, is the algorithm analytically valid as well? And like, a lot of these wearables will have algorithms underneath. Some of them are black boxes, so they don't actually give you the information that you need to evaluate that. Does it match a reference method with acceptable error, acceptable reliability, and is it used in the same real world context that we want to use it in, that our consumer health seekers would use that in? Is it clinically meaningful as well? Some metrics that we're provided might not connect to an outcome or a decision that actually matters. So we don't necessarily, in a certain context, need to be monitoring a certain metric. We need to understand which ones are the priority for the goal or the outcome that's desired. And usability, feasibility is really important, because a metric can be valid in a lab, but it fails in real life, because if people won't wear it, or if the data quality collapses, then it's pretty redundant. And so we have designed a technology framework at Cascaid. It's based off of the SCRN technology quality assessment framework, and we've adapted it for kind of what we do at Cascaid. And that framework assesses some key pillars, and that helps us to understand if our technology is valid, is doing what it says it's doing, and it's usable for us. So that would be kind of quality assurance and measurement, established benefit, ethics and security, because the compliance, privacy, data ownership is really important these days. User experience for both staff using it and also health seekers or consumers using it. Data management, which I think I mentioned, and practical considerations as well. Like, what's the cost of it? How much time does it take to use, etc. And those kind of pillars are the first five pillars I mentioned are based off the SCRN framework, and the practical considerations we've kind of adapted to our environment and our setting. And so we're still talking about trust here, which is the first thing I mentioned. There's kind of three other things that we kind of built in, but to give like an example, which hopefully makes it a bit easier to understand, if we think about VO2 max, is a great example of why we assess trust in layers. The gold standard to measure VO2 max, which is the maximum amount of oxygen you can utilize in a minute, usually measured. The gold standard is gas analysis in a maximal test on a treadmill, for example. But wearables also estimate VO2 max. Like, you would have seen it on your watch. It gives you an estimate of your VO2 max, and that's an indirect measure based off of your activity level. And so when we're looking at analytical validity, we're looking at how big is the typical error compared to that cardiopulmonary exercise test, which is the gold standard. And when we look at wearables, generally, this is a generic statement across the board, but evidence suggests that exercise-based wearables are better than resting estimates for VO2 max, but the individual error can still be large. So that means that wearables are usually best used for directionality, for trends, not like tiny week-to-week changes, because they're just not that sensitive. And so when we have that information, then we ask, does it change a decision for that health seeker's goal? If we see that change in a VO2 max from a week to week, we need to know, where did it come from? Was it a gold standard measure, a test, or was it from a wearable? Was it from a calculation? And can we capture that like reliably in real life? So building out this knowledge system, we have one metric, which is VO2 max, but that can be measured in different ways, and we have to understand the validity and how much we trust how that was measured and what that signal is. And then the second part is actually meaning of that metric or that signal. So what construct does that actually represent in that person? And so for VO2 max, that represents, so it might represent aerobic capacity in that person. And then we need to understand actionability. So with VO2 max, or will it change the plan this week if that VO2 max changes based off of the goal? So we might have already set that plan, and we have to have those rules kind of built in so that we know the directionality of how that should change based off of different context. And then safety is also a key thing that's built in for certain metrics as well, and especially for some blood biomarkers and some of our imaging metrics that come through. At what point does that need to be escalated to a clinician? At what point does that need to be referred out for further kind of medical assistance? And so all of those things are really important to be kind of baked in, but it's how we're linking everything together. It's such a massive undertaking, and it's very exciting because there's so much data, so many metrics out there, and actually linking metrics to constructs. And I think I'll explain a little bit later about what that means with our ontology, but we're trying to connect everything that maybe previously has been like really scattered. So yeah, it's hard to summarize it.
I think it's so key, and I think it's the bit that we have either forgotten or it's not been as sexy in some ways. Like, the data doesn't change like the outcome or the goal. It's the decision science or the decision intelligence that really does. And we've had like, I think of like 3 phases that have happened over the last maybe like 10 to 15 years, I suppose, of we didn't have data. So it's like, we need to go get data. Now it's like, we've had loads of data and there's no shortage of data, but it's like, what do we do with that data? And we're now at this stage of this, like, it's not the data, it's the decisions that go with that. And that's why also I think when people get worried about AI and what it can do, and it's like, AI can do what you tell it to do. So actually the human in the loop here, the practitioner, the subject matter expert from a physiology or a science point of view becomes even more important to actually inform the decisions alongside some of the standard frameworks you've talked about there around kind of ethics and safety, so that we know that you can trust. But like, it doesn't remove, in my eyes, the human from the loop or the practitioner aspect. It's just the tech helps aggregate that data so you can come to some decisions, but the decisions still need to be made. And I suppose it kind of links on to slightly something I wanted to talk to you about around like ontology and data standards in your work. Like, for people who don't live in this world, what does that actually mean, and why is this kind of like foundational element to everything else?
Yeah, and I would 100% agree in that human in the loop is critical, and we could never not have a human in the loop for this, like 100%. And so, yeah, for ontology and data standards, just so kind of everyone understands, I suppose, what that means in our environment. The ontology it's the brain, it's the shared language that links health seeker goals to the constructs, to assessments that might measure the constructs, that provide metrics, that links to interventions and then to outcomes, and it keeps it consistent across diagnostics, wearables, lifestyle, and kind of our staff, right, our practitioners, clinicians.
How does that differ, sorry to interrupt, like ontology to taxonomy? Like, what would you say, what's the difference, or is that a semantics?
I think with our ontology, it's almost like it's mapping those connections, and it has the applied science element onto it. So it's the actual doing as well.
Okay.
So it's almost the bridge to where we build and we deliver like specific integrated protocols.
Okay.
And that's based off of that underlying knowledge base. So it's kind of got that additional step to it where you're delivering that. It's a living system essentially, and it's constantly evolving. It's interdisciplinary. It encompasses aspects of what to measure, how to interpret change, over time using normative data, using baselines, how to develop integrated plans across multiple different constructs, domains, nutrition, strength and conditioning. It could be psychology, behavior change, which is really important as well. So multiple different areas, but I think we're trying to build the translation layer that turns it into decision. So like I said, there it's the actual doing. It's not just the language of this is this. It's the translation layer of, okay, this has happened. These are the directions we could take. This is what we could do. This is how we do it, and then let's go. So I suppose an example of that is, let's take heart rate for example. If a health seeker has a raised resting heart rate, that resting heart rate is essentially, it's just a number until the ontology tells us whether it likely maps to sleep debt, illness risk, training load, or stress, and then it tells us what to do next. So it builds that layer around it rather than just looking at the isolated metric by itself.
And if you like, consumers generally, and this is a generalization, like quick fixes. They like kind of things that they can not have to do the work for, or like instant results. And that's probably been led by a bit of kind of it's led by marketing, social media, instant gratification. We're talking here about like proper science, and I'm using that in very layman's terms, but actually what physiologically happens in the body. And that, again, it takes time to either measure that or see the change in that. Like, how do you marry that with people's wishes? And maybe it's not really like a marketing question, but it's like there is a behavior element there that we know that, like, we've seen this visual loads of times. It's like the difference between taking a pill and actually doing the exercise that you should do. How do you build that into kind of that decision element aspect of it?
Yeah, I think behavior change is really important. And it probably sits into our system, into our kind of 3-layer, like say it's like a 3-layer system that we kind of build. And that's, firstly, it has to be easy, like you've just said. It has to be easy for the health seeker, the consumer, so it doesn't feel like a big step or a big chunk. And so in terms of navigation, we have to make that next decision easy. So it's one priority, one next step. It's not loads of different options and loads of different choices. We have to guide them on that journey. And a part of that is accountability, like we mentioned previously. There's a human team, and it's human cadence with check-ins. So there's humans at every step, but the compounding is the important thing here for behavior change, and it kind of links into not just having a goal for right now. Like, that's the difference with elite sport. Elite sport is, we have a performance problem, but we also need to win on Saturday. We need to win at the weekend in 3 days' time, or we need to win the league this season. That's like a really, in the grand scheme of life, that's quite a short-term goal. But when we look at consumer health, it's not just planning for that short-term goal of this year. It's like, where do you want to be in 10 years' time?
Yeah. And you would guide that with them as part of kind of like a conversation of goal setting.
Yeah, and I think that's goal-based care. Like, it's almost the difference between that is, if you're looking at goal-based care compared to symptom-based care, like symptoms ask what's wrong today, and goals ask where are we going.
Yeah.
Goals decide what we measure, what we ignore. We're trying to build health around goals, not just a symptom. So be proactive rather than being reactive. And you're trying to meet that person where they are, help them to get to where they want to be. And so, where do you want to be in 10 years, not just in 3 months? And that's then translated into maybe it is like a goal-based dashboard, it is some reports, it's some discovery calls to understand where they are right now, where they want to be. It might be a wellness vision and understand what they want to look like, what the outlook on life is, where they want to get to. And so based off of all that information, then you understand what are maybe the kind of top 3, 5 constructs we should be focusing on in this period of time. That might be cardiovascular health, it might be metabolic health, a behavior might be sleep. How can we change sleep? And then we set that review cadence. So almost the goals become like the GPS to like navigate them on the way. But in terms of actually helping them with those easy wins and getting to that process, that's where compounding comes in. And that's really important in terms of behavior change. And so compounding is like small steps that really stack up, and it's habit stacking really. So you attach a new behavior to an existing stable cue, like brushing your teeth. And so that cue, we know that could reliably trigger the new action because you brush your teeth twice a day. Like that's a habit. And so that's one of the key things I think that you have to build in when you're trying to help the health seeker get to their goal that might be in 10 years time, but they want an instant win. So there's small things that we can help them change. In elite sport, like the compounding comes from the consistent basics that elite athletes will do every day, and they get feedback for it. Habit stacking is probably the consumer health version of that. And so we tie like one small action to an existing routine, so it happens automatically for them. And then those small wins, they compound over time.
Yeah.
And the ontology for us decides what matters most based off of all of that contextual information, diagnostics, intake information, the goals that we get from the health seeker. Then we can identify where some small wins could happen. Applied science turns that into the integrated plan, the bridge, which is the part of the ontology as well. And that habit stacking it's really how that plan survives, like real life, when you don't have a support team around you every single day, because it's built into existing routines. It's not reliant on willpower of the health seeker, because we all have the best intentions, but sometimes if you don't have someone with you all the time, it's really hard.
And you can't create it off motivation like that. Yeah, it just doesn't work. But that's what you've kind of talked about there. It's like in elite sport, as you say, you've got those kind of clear goals: win, recover. Like consumer health, day-to-day life is much messier than that. It's like feel better, have more energy. Like it does require. But what you said about that brushing your teeth, like as a physio, that's what we used to be like. Someone, for an example, a sprained ankle, like you're not they're living their life, you can't expect them to do the rehab that you really want them to do. So it'd be like when you're brushing your teeth, when you're waiting for the kettle to boil, like balance on one leg. Like you have to find ways to fit it in and be relatively, I'd say, much more creative than you have to be in sport, because you're having to pinch time off people that they don't really have to give you. So yeah, there's so much there around the psychology and the behavioural element that I think is underestimated, and probably why definitely in the UK, like NHS systems can't deliver this, because we don't have the amount of time or thought put into the systems. It's just reacting to the problem in front of you at that time. Naomi, I really want to pick up, because you've got such a breadth of knowledge in this around the female athlete and female health. Like you were involved in different projects there with the FA, with City Football Group as well. How do you, like, what does women's or the female health strategy look like in the work that you're doing now? How do you take all that years of knowledge and work that you've done across different projects and apply it to the kind of consumer health world that you're in now?
Yeah, well, female health is kind of one of my passions as well. And so like you said, I've worked in I was at the FAs where I did my PhD for about 4 years, and then I moved to City Football Group. And in both environments, I worked in an amazing team who had female health at the forefront. So I was really lucky to be in those environments at that time. So I've definitely picked up a lot. And yeah, I think I probably should shout out kind of the amazing women I've worked with who are pushing female health strategies and female health research forward into the forefront of sport. Stacey Emmons at the FA and at UEFA, she was my supervisor on my PhD as well, but she's doing great work with that at the minute. Rachel Dorr, who was at City Football Group with me, and Emma Deakin and Rosie Anderson, who are at Man City Women, and they're doing great work with their female athlete strategy there. At Man City, really leading the way, I think, from a biased perspective, obviously being in that environment. But
I can be biased to that too because I work for Hycho, who are partnered with them on some of that work as well. So it's great.
exactly, and even now I work with some kind of incredible physicians, health coaches, nutritionists, S&C coaches at Cascaid who are working really relentlessly to prioritize female health, which is so refreshing. So yeah, I guess all of that kind of amalgamation of those different environments, you pick up different things, and so in the work that we and I are doing now at Cascaid, it's really important representation matters. So we have female specific evidence and baselines. We're not just taking evidence that has only been done in male athletes or male health seekers, general population. We are using specific women-based evidence and baselines, and also considering life stage and context, which is really important because the category isn't just woman or female athlete or person at certain stage. It's multiple stages. So you have things like hormonal fluctuations within the menstrual cycle. We also have contraception, perimenopause, the menopause, pregnancy, postpartum. So where relevant, we are trying to map our recommendations, our constructs, metrics in the context of those stages of the female, because that's super important. And there's perimenopause and menopause especially, there's really a lack of research around that life stage in females. And so we have some really cool people on our team who are really doing such great work in that area, and we're trying to build that out, and that's really important to us. For our health seekers, one of our main focuses, we're open to everyone, but one of our main focuses is female health seekers and female health, and that's really big for us. And so things like understanding early detection, cancer prevention, particularly in females, is really important too. So that's important for us. Our system is designed to not make women the exception. It's
Okay.
to build female physiology into the defaults. And I think that's something where in some environments it almost is the exception, and it's getting a lot better, which is great. We're getting more and more research on, but it shouldn't just be let's just have kind of 1 week on women's health, or
Yeah.
that happens a lot with the best intention, but it should be a default because female health isn't a niche, it's half the
No.
population. So
But when
yeah,
we know the reality is that it's under-researched and underserved, and we do have a lack of data, and that's like why it compounds the problem that we take male data and apply it to these settings. Like, what do you do? Do you take, as a starting point, do you take that, or do you just say, actually, we can't create any decisions until we've got the female health data to move forward?
I think it's context dependent. There are some principles that stand, kind of whether it's male or female, like training principles, for example. Some of them do stand, but kind of overall, in general, we're trying to find that female specific evidence base.
Yeah.
And that's something that we're gathering at the minute, but as Cascaid, we will start to build them and research ourselves as well to contribute to this area. And we
Yeah.
want to collaborate because we can't work in silos. We should all be working together to build our knowledge base around the female, whether that's an athlete at the top end of their sport, or whether it is a weekend warrior or a general health seeker, whoever it is, and at whatever life stage they're at. So we're trying to gather the existing evidence where we can. Where we don't have that evidence, we take our expert-led knowledge base, and so a lot of that might be kind of specific recommendations based off the context of the health seeker at that time and the experience that our clinician might have in those environments. But we're consistently trying to consolidate all of this so we can build that base and work from that going forwards. There's obviously gaps. There is, and that's just where we're at the minute. We're trying to close those gaps as much as possible, and that's where collaboration comes in for sure.
Yeah, definitely. Alongside kind of consumer health, you can't really not talk around longevity and human optimization, and it's quite a crowded, there's trends, there's hypes that kind of come through it. What makes an approach different from kind of biohacking? Like, how would you create that credibility within this space?
Yeah, I think you're right. It is an exciting space to be in, but again, it's kind of similar to what I mentioned with the technology and the number of metrics. It's really important to like wade through it, but having a credibility checklist, so to speak. So is it evidence-based and transparent about uncertainty? Because there's definitely uncertainty in this space, in this biohacking space, if we're going to call it. Not everything's certain, right? So you have to be honest about that, and it's fine. It's okay to say, we're trying this, we're not sure if it's going to work. That's fine, because you can be on the edge, but just be transparent about it. So that's one thing. I think prioritizing fundamentals is important. So your basics, your foundations, like sleep, movement, nutrition, stress management, social connectivity is really important. And is it personalized by like context of the person, the health seeker, and not just trends that say everyone should do this because this is the next trend, or actually that might not be relevant for one person compared to another person? Is there clinical education that's built in? Like, that's really important, is empowering the health seeker to actually educate themselves, or giving them the tools to so that they can understand what it is that they are then doing or interpreting with, even kind of the wearables you wear on your wrist, right? Some of them are quite good at giving that education, and some of them could do better. So that's super important. And then for me, I think it's measuring outcomes, not just outputs. So, for example, if we take let's say we take cardiovascular health, for example. Someone has like risk factors for cardiovascular disease. Their blood biomarkers might be in that area, might be slightly elevated. So we want to actually, one thing might be we want to improve their VO2 max, because that's actually really quite low for their kind of demographic. We don't just want to focus on, their VO2 max is increased, so that's great, they've done, tick. No, what's the outcome? The outcome should be reduced cardiovascular risk, not just increased VO2 max. And so that's really important. Is sustainability, like, if is it actionable? Is it safe? Is it sustainable? Does it compound? So trying to make it simple to make smart decisions for the health seeker. Essentially. Yeah. So I hope that gave a good enough answer.
It does, because what it tells me is the thought process that goes behind what someone might actually see kind of as the front end. It's like the knowledge base that you have around risk, utility, R&D, like the scientific principles, the foundations, the systems that kind of go behind that, rather than this did something. It's like a point, but with no context kind of around it. And that's what sometimes people jump on and then realize, it didn't create any difference. It's like, well, like, not a surprise, because health is quite complex. That's why we have a really interconnected system and experts in this area. So yeah, I really, like, if there's one message that I would, all through, I suppose, my career, I agree around that empowerment. Like, you can only be given certain amount of tools to help you yourself, but unless you're going to take ownership and interact with your own, with the people helping you, but also knowing and being kind of the driver for your own body and your own health, then there's only a certain like level that you can kind of achieve with that. Naomi, you've worked with elite athletes kind of chasing medals. You're now helping build something for everyone and has the applicability, Cascaid Health, to work across so many different domains for people. Which would you say is harder, but also I suppose which matters more to you now?
Oh, that's a tough question. That's hard. You've killed me with that one at the end. Um, I'm absolutely passionate about elite sport. Just the thrill of the win, the ups, the downs, like the stress you get from it. But like it's amazing, and I think a lot of people feel that way. That's why we watch sport. Um, but I think if I was gonna say what's harder, I think almost they're both very very hard. But the consumer, because there's so much ambiguity, there's so
Mm,
many competing priorities, and at times the feedback can be slow, and that's what we're trying to speed up. I think in terms of what matters more, I'm going to kind of sit on the fence and say everyone, but
yeah,
because the upside is population level impact, because even if you're an elite athlete, you're still your goal should you should still have the long-term goals. Where do I want to be in 10 years in my health? So it's not just obviously in an elite environment, it is about winning and losing, but for the athlete themselves, it's also about where they want to be in 10 years time, like in
yeah.
terms of their longevity. So I think it's, yeah, I'm trying to make the best of the elite methods that kind of I've used in the past and what's available, and translate that into the kind of consumer environment. Elite sport is high stakes for a few, but proactive health is high stakes for all of us, is what I'd say. And elite athletes still fit into that
Yeah,
proactive.
yeah.
So
I think that's a really lovely way of summing it up. But athlete longevity is probably something not always focused on at that moment because it's a competing priority to the win in 2 days time aspect. But there's something that I think you've mentioned there that I think is really important that we kind of think about is that data of an athlete does belong to them, and also it's their health long term as well. And systems don't always, we wanted the data, give us the data, but actually there's a person behind that, there's a human behind that. And as you say, if you take that goal-based approach of what does that person in front of me at this point need now and in the long term, then that kind of, I would hope that marries some of the kind of moral and ethical sides that this whole area can kind of create when we're in this consumer data tech intersection and world there. Do you have thoughts on that?
yeah, I agree, and I think they don't have to be at odds with each other. Like the goals to be successful in the sport and win, but also the long term goals of what happens after your career and longevity. Actually, like promoting longevity while an athlete's in their career might have a benefit on their actual performance. Like it's not going to have a negative effect. And so all of this data is being collected on those athletes. And like you said, there's also big conversations at the minute around it's who owns that data. The athlete owns their own data. So the athlete should feel empowered to request that data. So they have a record of that and ask questions and interrogate that data as well. Why is this test being run? What does that show? And so, and a lot of teams are doing this already, which I have to say, in my experience too, they are looking after the athlete, and it's not all just about performance on the
No.
pitch. But that is a really key thing, and I think you'll start to see that over the next kind of 5 years, athletes taking ownership of their own data, and sometimes even kind of employing external kind of a team around them. And this is what happens in the US, and this I think might start to happen in the UK. It's quite common in the US that athletes might have their own team to support them in terms of that longevity piece as well as the performance piece too. And
Yeah.
so it might happen, but I think it's going to be a real watch this space moment for athletes and kind of taking ownership of their own data.
Yeah, yeah. Naomi, thank you so much for your insights, thoughts. It's kind of a fascinating, evolving, and like you're right at the forefront of delivering it into a service and a product as well. So looking forward to seeing the platform launch. Thank you so much for your time.
Thanks. I've enjoyed the conversation.